Hi, I'm Dr. Susan Rehm, and I'm pleased to be back to talk with you a little bit more about a special aspect of adult immunization, and that is vaccines for immunocompromised adults and pregnant women. I'm the Vice Chair of Infectious Disease at the Cleveland Clinic, and I'm also the Medical Director for the National Foundation for Infectious Diseases, which is one of the reasons that I've gotten so interested in vaccines as well. I am a member of the Scientific Advisory Boards for Merck and Pfizer. Our objectives today are to look at considerations for immunizations of various special populations. I want you at the end of the presentation to be able to list at least 3 live virus vaccines, and then I want you to be able to talk a little bit again about herd immunity and why it's important in the care of immunocompromised individuals. If you haven't done so already, I would encourage you to go to the CDC site and look at the adult immunization recommendations. And for the purposes of this talk, we'll look very briefly at the age-based recommendations, but we're going to spend a lot more time talking about the recommendations that are contained on this indication-based adult schedule. And specifically, we are going to talk a little bit about pregnancy, which is the first thing on the left column of indications. We are definitely going to talk about immunocompromising conditions, including HIV infection. We're going to talk about asplenia, which is about in the middle of the indications there. And we're also going to talk a little bit about healthcare personnel and their need for immunizations too. Before I leave this slide, 2 points. Number 1, don't forget to look at the notes. You can see there are a few footnotes listed here, at least numbers that refer to footnotes. The footnotes themselves really contain the meat of the recommendation, and they will answer 99% of your questions about immunization for immunocompromised adults. You should know that there is basically an immunization hotline at CDC. If you have questions that can't be answered through this or through your local resources, don't hesitate to call the CDC. They're very helpful, and they want you to be aware of that resource. The second thing is, note on this slide that there are 3 red bars. These red bars refer to contraindicated vaccines for certain immunocompromised individuals. And these are live virus vaccines. Now, the first one, varicella, is one that we don't use very often in adults because most adults have either had chickenpox or had, if they're a little younger, have had chickenpox vaccine before they grow up. Zoster vaccine, which is basically a high-dose chickenpox vaccine, is contraindicated in very immunocompromised adults, as is measles, mumps, rubella vaccine. Those are live virus vaccines. And so I want to highlight the red ones, and I believe we'll talk a little bit more about live virus vaccines coming up. Well, immunocompromised individuals constitutes a wide range of people, a wide range of conditions. And here's a disclaimer. I am not going to talk about vaccines for solid organ transplant or patients who have received bone marrow transplants. That is highly specialized. It's something that if I were in your position, I would refer to a specialist for, because they're very, very difficult. Basically, when somebody gets a transplant, you have to start out as if they've never been vaccinated before. So aside from that, we are going to talk about a range of immunodeficiencies. One of the things that I want to also emphasize is that if you know that a person is going to be immunocompromised, and that may mean going into cancer chemotherapy, or somebody with Crohn's disease who's going to be receiving a biologic agent, that type of thing, while you do what you can beforehand, it's very important that you do that, because the person will be able to process their vaccinations much better if they're immunologically intact. One of the classics here is the elective splenectomy. We really emphasize that people need to get their vaccines before the splenectomy when at all possible. Now, when you look at various immunocompromising conditions, I think that the specialty societies have been attentive to it, but some more attentive than others. Now, I put up this slide for the American College of Rheumatology recommendations for vaccination of patients with RA, because they really break it down into disease modifying monotherapy, combination therapies, anti-TNF biologics, and non-TNF biologics. This is really quite helpful, I think, as you look at these patients. And note also that they break it down by vaccines that you give before initiating therapy and vaccines that you can give while taking therapy. They aren't that different except for zoster vaccine. Now, and that's one of the reasons it's so important to anticipate what therapies are going to be started. If you can get in something like a zoster vaccine before the immunocompromised, that's very, very helpful. All right, let's talk one more minute about live or live attenuated vaccines. There are actually several that are out there. Now, the interesting thing is things like the live attenuated influenza vaccine, trade name for that is FluMist. Those types of live viruses are actually probably very, very low risk, even to the most immunocompromised individual. The live attenuated influenza vaccine is engineered such that it only replicates in cold, which means just in the nose, in the human, basically. And there have been no cases that I'm aware of person-to-person transmission of these vaccine strains. So these are all kind of variable, but in general, any live virus vaccine administration should raise a red flag in your practice. And when in doubt, do not give it. Do not give a live virus vaccine to someone who's immunocompromised. Let me talk a little bit about the zoster vaccine in HIV, because we are able to give zoster vaccine to HIV-infected patients whose immune system is intact. And as we're treating earlier and earlier, we do give zoster vaccine to these folks, because if their CD4 count drops, they are really at very high risk for getting shingles and for getting post-herpetic neuralgia. Just a note to those of you who may have received oral polio vaccine as a kid, we really don't use it anymore. So it would be quite unusual for this to be an issue. But there it is, and something to be aware of. Well, let me talk first about pneumococcal vaccine, because this is extraordinarily relevant to you if you take care of people with various types of immunodeficiency. In general, we are very undervaccinated against pneumococcal disease in the United States. And you can see on the right-hand side of the slide that the immunization rates in adults 65 years of age and up is okay, not great. They've set a low goal of about 65%. It does vary somewhat by ethnic group and race. But for individuals 19 to 64 years of age with high-risk conditions, and this is not just immunocompromised, but just things like smoking, asthma, diabetes, that kind of thing, we're really far below our target area. So we've got a lot of room for improvement here. We've talked a little bit about the fact that invasive pneumococcal disease has gone down dramatically in the era of conjugate vaccine use for children. Because children carry pneumococcal disease in their throats, presumably that's how adults get it as well, through transmission often from kids. As their rates go down, adults' rates have gone down dramatically. But with time, what we've seen, even though the number of serotypes in the childhood vaccine increased from 7 to 13 a few years ago, we see what they call replacement disease, and that is pneumococcal disease that is related to strains that are not in the vaccine. And these affect kids as well as adults. Serotype 19A is kind of a notorious one. People ask me all the time, well, what's the difference between the vaccines? We have the Polysaccharide vaccine, which we've had for adults for a number of years. It's got 23 serotypes contained in it. We have, and that's the Pneumovax. Prevnar started out as a 7-strain and now is a 13-strain vaccine, and it's just got an indication for immunocompromised adults. So you may ask, what is in both, what's in neither, and so on. This is how it breaks down. We are going to still use Pneumovax because there are many strains that are covered by Pneumovax, the polysaccharide vaccine, that are not covered by Prevnar. And this, you could say, is a bit of a belt and suspenders approach or whatever, but it's giving the best chances for coverage through use of both the Pneumovax and the Prevnar or the conjugate vaccine. There's also differences in how the vaccine is processed, and then this is very relevant to immunocompromised adults who may have defects of both cellular and humoral immunity. So the point of the slide is really to tell the difference between the polysaccharide and the conjugate vaccines. We know the polysaccharide vaccines are not immunogenic in children who are less than 2 years of age. Both polysaccharide and conjugate have a B-cell dependent immune response, but with the conjugate vaccine, there's a T-cell dependent immune response. So theoretically, in individuals who are immunocompromised, particularly those who have cellular immune deficiency, this should be helpful. In addition, the conjugate vaccine has an immune memory property. It has a booster effect, hopefully has longer-term protection. We've mentioned reducing carriage, and potentially, through reduction of carriage, some positive impact on herd immunity. So there are reasons to do both. Now let me go back again and review this slide with you. This is the current pneumococcal vaccine indications. Everyone over 65 years of age and older, should get polysaccharide vaccine. In addition, immunocompetent individuals between 2 to 64 years of age who have underlying medical conditions should get polysaccharide vaccine. Immunocompromised individuals between 2 and 64 should get polysaccharide vaccine. And these are conditions like leukemia, lymphoma, various congenital or acquired immunodeficiencies like HIV infection, chronic renal failure, nephrotic syndrome, and various conditions requiring treatment with immunosuppressive drug. The new recommendation is that pneumococcal conjugate vaccine should be given in addition to the polysaccharide vaccine for certain immunocompromised adults. So who should get the conjugate vaccine? Congenital or acquired immunodeficiencies is a big one. HIV infection, chronic renal failure, leukemia, lymphoma, Hodgkin's, any disease requiring long-term treatment with immunosuppressive drugs, including long-term corticosteroid use. And we usually use a definition of 20 milligrams a day or longer for 3 months or longer, but there is a little bit of interpretation that's used there as well. Solid organ transplant, multiple myeloma, functional or anatomic asplenia, and then the small segment of patients with cochlear implants or CSF leaks. All of these individuals should be getting conjugate vaccine as well as the polysaccharide vaccine. And remember, timing is important. If the individual's never been vaccinated against pneumococcus, they can get the conjugate vaccine and get the polysaccharide vaccine 8 weeks later. If they have had polysaccharide vaccine, they need to wait at least a year before they get the conjugate vaccine. And remember that revaccination is recommended in 5 years for a number of individuals who have been vaccinated with the polysaccharide vaccine before age 65. This table from the CDC attempts to summarize the entire concept and to give you some guidance on who needs to be revaccinated as well. And I encourage you to take a look at this at your leisure and kind of get a sense of it. What strikes me as I look at it is that there are a ton of patients in general primary care practices, general internal medicine practices, who should be getting both of these vaccines. I'll talk briefly about influenza vaccine. We had a chance to talk about this in our other session as well. There have never been as many opportunities for influenza vaccine, not only in places to get it, but also types of vaccines that can be given. The live attenuated influenza vaccine is contraindicated in people with severe immunocompromise because it is a live vaccine. And remember that the cutoff age is 49 years for the live attenuated vaccine. Pertussis, still a problem. And here is where cocooning is really important. I bring this up because some of your immunocompromised patients will be parents and grandparents, and it's relevant for protection of children less than a year of age, less than 18 months of age, who themselves are not immune to pertussis. We do want to protect them, and we know rates went way down, but rates of pertussis are going up here. For adults, there are 2 forms of Tdap vaccine available. They both have different FDA indications, but they're in practical use interchangeable. And we've talked a little bit about these updated recommendations. We do want pregnant women to get vaccinated with each pregnancy, and that would include immunocompromised individuals. Shingles vaccine. Remember, it's different than the chickenpox vaccine, and it is a live virus. So your most immunocompromised individuals will not be a candidate for shingles vaccine unless you're lucky enough to be able to give it to them before they become immunocompromised. And I will tell you, however, that there has been one study, and I expect there will be more, looking back at individuals who were on biologic agents or other immunocompromising treatments who inadvertently got zoster vaccine, and they all did well. This is kind of a neat study. It is one of those megadata studies, so if you don't like megadata, you won't like this one. But the bottom line is that even individuals who were receiving pretty heavy doses of immunosuppression for their disease were able to get the shingles vaccine. They did well. Now, this is off-label use. I want to be clear. I'm not recommending this, but if it happens to happen, it seems like people do pretty well. But I would say, and this is another off-label comment, that if somebody 50 years of age, for example, has rheumatoid arthritis and is going to go on an anti-TNF agent, I would personally vaccinate them against shingles before they get that treatment, even though it's below the CDC recommended age for vaccination. It's your opportunity to give them vaccine before they become immunocompromised and even higher at risk. For women of childbearing age, really the vaccination recommendations are the same as they are for other adults, but I think that what we need to continue to do is educate ourselves, our OBGYN partners, as well as our patients, about the need for, as well as the safety of vaccine in individuals of childbearing age. And in particular, influenza vaccine on a yearly basis for pregnant women is extraordinarily useful. We know, based on our experience in the pandemic, that pregnant women are at higher risk for complications themselves. As a matter of fact, the death rate was much higher in pregnant women than it was in other women of the same age during pandemic. And we know that women who are vaccinated have healthier babies. Whether they are known to have flu or not, their babies are a little bigger and they are usually closer to term than individuals, babies of individuals who have not been vaccinated. And then there's also the added boost, so to speak, of the fact that mother's protected against influenza, hopefully baby will be protected as well. Dad, grandma and grandpa, babysitters, neighbors, kids, the rest of the family should be vaccinated as well. Just be aware, live virus vaccine should not be given during pregnancy. As pregnancy advances, the individual has a relative cellular immunodeficiency, and that puts her at risk for complications, disseminated disease, if she is given a live virus vaccine. And there were recent studies that indicated that not only should pregnant women get Tdap to protect against pertussis primarily, but that they should get it with every pregnancy, because the protective antibody level actually drops very rapidly. So this is a brand new recommendation as well. This is my partner, Sharif Masad, who is a major vaccine advocate. And every year our MAs look forward to the time that they can give him his influenza vaccine. He is not getting double dosed, but I think they fantasize about that. So let's talk a little bit about vaccination of healthcare workers, because vaccination of healthcare workers is part of a cocooning strategy for protection of immunocompromised individuals. We don't want to give whatever we have to immunocompromised individuals. So this gives me an opportunity to talk very briefly about herd immunity. I think we all understand the concept, but the science behind it is really kind of interesting, and I want to hone in on just a couple of things. First is this so-called R0, or basic reproduction number. The R0 is the number of secondary cases generated by a typical infectious individual when the rest of the population is susceptible. So if I'm sick, how many people am I going to spread it to? Critical vaccination level, or VC, is the proportion of the population that has to be vaccinated in order to achieve the herd immunity threshold, that is, cutting off of transmission. And then vaccine effectiveness, you can see the definition here. The critical vaccination level, the basic reproduction number, and the vaccine effectiveness vary with various vaccines and diseases. I'm going to show you that here. As an example, the R0 in example A is 4. So for each infected individual, 4 susceptible individuals will become sick. And in the situation in panel B, where in the shaded block are people, or shaded circles, people who are immune, looking over the left side from the person who's infected, you will cut down transmission dramatically, assuming that there are 75% of people vaccinated in the susceptible population, otherwise susceptible population. This slide demonstrates the fact that there are varying R0s and varying herd immunity thresholds by disease. So one of the most contagious diseases is measles, where the herd immunity threshold, the number or percentage of people you need to vaccinate in order to protect most everybody else, is close to 100%. Interestingly, the herd immunity threshold for influenza A is somewhere in the 80% range. So if we could get 80% of our population vaccinated, it would dramatically reduce transmission there. We obviously get exposed to influenza virus during the course of our care. We know that the virus spreads with at least 6 feet when somebody coughs or sneezes. And this exposure is primarily through small particle aerosols, not through droplets. We also know that physicians and other healthcare workers go to work sick. And this was a survey that was done among resident physicians as to why they worked when they were ill. Basically, didn't want to have somebody else have to cover. They felt pressure. There's a certain macho part of, going to be at work no matter how crummy you feel and so on. But the bottom line is that when we go to work sick, we are putting our danger and our coworkers at risk as well. I'm not going to go into great detail for vaccination of healthcare workers. There's a lot out there on mandatory immunization against influenza, but there are a number of other vaccines that all healthcare providers should get, and they're listed here. There are some new guidelines for proof of immunity, for example, against chicken pox, against measles, and so on down the line, but I'll let you take a look at that at your leisure. Our influenza vaccination of healthcare providers is still suboptimal. In this particular study, 86% of physicians were vaccinated, 78% of nurses, and then I want you to look in the down at by work setting. 77% of individuals who worked in hospitals, 68% of people who worked in physician offices, just over 50% of people who worked in long-term care facilities. And ironically, that's the one area where we have the best data about the efficacy of immunizing healthcare providers and preventing spread. So in this study of nursing home staff, the higher the percentage of staff who were vaccinated, the lower the death rate among people who were in nursing homes. So the vulnerable people around us really benefit by our vaccination. And I'll just add that vaccination of children is extraordinarily important. A few years ago in Japan, there was a national mandate that all children get vaccinated against influenza. And what this slide illustrates is that morbidity and mortality related to influenza went down not only among kids, but more importantly among adults. And as soon as that mandate for childhood influenza immunization was lifted, those rates went up again. So when we think about vaccinating healthcare workers and doing a cocooning strategy, we should think about vaccinating the children of healthcare workers as well. Well, what I've tried to do in the last few minutes is to talk about healthcare provider vaccination and its relevance to the immunization of immunocompromised individuals and pregnant women. Please pull out the CDC recommendations. It's a great guide as you deal with patients who have varying degrees of immunocompromise as to what immunizations they should be receiving. Thank you very much.